I'd like to thank SCONA for the opportunity to present some collaborative work that was done between the University of California, San Francisco and the laboratory of Dr. Kai Zhao and Barak Spector at Ohio State University, with input from colleagues both at UCSF and the University of Washington. Neither I nor any of my co-authors have any disclosures to make. By way of background, the physiological roles played by nitric oxide in the airway include suppression of microbial growth, stimulation of ciliary motility, and regulation of regional blood flow. The concentrations of nitric oxide found in the upper airway are highest in the paranasal sinuses, which are sometimes referred to as a quote-unquote reservoir of nitric oxide. Sinus concentrations tend to be approximately 2 orders of magnitude higher than the levels found in the nasal airway. Depending upon the specific sampling method used, these levels in turn tend to be 2 to 3 times higher than the levels found in the lower airway. Nitric oxide sampled orally, bypassing the upper airway, are generally referred to with the acronym FeNO, or fractional exhaled nitric oxide. The data that form the basis for the collaboration come from a study that was completed at the University of California, San Francisco, approximately a decade ago. And what is somewhat unique about this data set is for each of the individuals studied, they had a sinus CT scan obtained on the same day that they did real-time NO monitoring. These are the demographics of the individuals who we studied. Importantly, none reported a history of asthma, none were current smokers, and none gave a history of chronic sinusitis or prior sinus surgery. This is an example of the type of data that we were able to use for this reanalysis. The red arrows point to the plateau phase of individual nasal exhalations done under quiet conditions, that is not acoustically stimulated. And what we did find in that previous study is that when we compared the height of those plateaus with the combined osteometal complex cross-sectional area between the two heminasal cavities, we were able to successfully model the two together. So that constitutes the one shaded box in this overall design of the study. The other half would be individual simulations. And in order to do that, we took individual anatomy, that is CT scans, along with standardized sampling conditions, and finally published data on nitric oxide levels found in the paranasal sinuses to produce individual dynamic simulations. So we then had a time series, if you will, of observed and modeled values, and that allowed us to do the comparison in this study. I'm not going to belabor the mechanics of creating a CFD model or a mesh model. That's actually not my area of expertise, but I would bring your attention to the bottom right of the dynamic simulation illustrations, in which you see that for both the maxillary sinus and the ethmoid sinuses, during steady state exhalation, we do not anticipate that it will be significant convection or air movement through the sinuses. So the collaborative study involved 10 subjects from our original study with the dynamic simulation we just described. So we had modeled and observed NO values, which we time matched at 0.1 second intervals during the initial 2-second transient exhalation period. And we didn't look at the plateau because actually we had adequate power to model that simply with a morphometric study. We compared these values, approximately 21 values for each individual simulated and observed using a correlation coefficient. And the individuals who comprised this substudy of 10 were equally divided among allergic rhinitis and non-rhinitis, and importantly, did not include individuals who had accessory ostia. When we look at the results, using a color code with orange indicating experimental findings, blue the simulation, and then red what would happen with the simulation if diffusion were set to 0, we see that we go all the way from very good correlation on the left side to fairly mediocre on the right. So the question is, why is this heterogeneous behavior observed? So we took the 10 subjects and we stratified them according to the correlation coefficient and corresponding p-value, and using a cutoff of p equals 0.001, we indicated that individuals whose p-values were under that would be considered part of the main group, and arbitrarily the 3 whose p-values were greater than that would be considered outliers. And the question is, what variables did we not take into account that might have helped us bring these outliers into the fold, if you will? So it turns out that allergic rhinitis status by itself did not predict individuals who were going to perform poorly with this model. However, if we looked at FeNO, which is NO sampled from exhalation from the chest without the input of the upper airway, we see that all the individuals who are outliers had elevated FeNO values. So an elevated FeNO value included, it was sensitive to these outliers. It was not specific, however, for those outliers. So to summarize, in a subset of 10 subjects reanalyzed from a published study, anatomically based CFD modeling, which assumed a fixed source strength regardless of rhinitis status, did produce a significant correlation between experimental and model data. Mechanistically, diffusion constituted an important first step in sinonasal NO flux. Something I haven't mentioned already, but quite surprisingly, the ethmoid and sphenoid sinuses appeared to be a more significant source of NO flux than the maxillary sinuses, despite the difference in their overall volume. And elevated FeNO, but not allergic rhinitis status, predicted diminished model performance.